right? So learn this list. This is the most commonly tested aspect of breast conservation surgery in terms of indications, contraindications. All right. So what's the difference between that and a modified radical mastectomy? Well, breast conservation surgery, you're conserving the breast. Modified radical, we mean radical as in lymph nodes. We mean modified as in it could have been radical before. And mastectomy means mass cut out the breast. So there are a few things that we remove in a modified radical mastectomy, and I know that most students don't actually know what it is, so I took the time and the liberty of writing out for you exactly what it is the surgeons take out. Okay, so let's learn that. Nipple areola complex, skin envelope, the whole breast, the pec facial, level 1 and 2, and in some cases, the level 3 lymph nodes and their eponymous names, the patties and Scanlon's procedures, and so on. All right. The difference between a radical mastectomy and a modified radical mastectomy is that in a radical mastectomy, it's very radical indeed. They take out the pectoralis major muscle and they even remove the ribs, right? Whereas in a modified radical mastectomy, we keep in the pecs, we keep in the ribs. So definitely less radical than the actual radical, right? So that's how I remember it. That was a radical thing to do. We take out all the woman muscle and ribs and so on. So modified radical, we spare the pec major, take out the ribs. And of course, the indications for mastectomy would be the contraindications to breast conservation surgery, and then locally advanced breast cancer, etc. Right? So we kind of got the gist of that. What they love to ask, however, guys, is the complications of our MRM. And for some silly reason, I got this wrong when I did my exams because I forgot what the answer I chose was, but they asked which one of no, I remember the answer. The question was which one of these is not a complication of MRM, right? And the options were the obvious ones, so seroma, wound infection, and the other two options would have been skin flap necrosis or numbness of the lateral arm. And I, like a stupid fool, put skin flap necrosis because all my life I know it is get numbness of some part of the arm, right? So those kind of small words make a big difference. So to clarify, the complications of a MRM, the most common would be a seroma. Skin flap necrosis is a very common complication. Positive margins, that is, you have residual tumor left behind, you didn't clear the entire tumor. Wound infection, wound dehiscence, of course, simple surgical complications, hematomas, things like that, right? But very specific to MRM would be our skin flap necrosis. And for that reason, when the surgeon is making a skin flap, the ideal size is 7 millimeters. Too small increases the risk of necrosis, too large increases the risk of seroma and retaining fluid and all of that kind of stuff, right? So those are the complications of the MRM. And then the very specific complications, remember MDR stands for radical, when removing the level 1 and 2 lymph nodes, the axillary lymph nodes. The other specific complications would be that involves surgery to the axilla. And so brachial plexus injury, long thoracic nerve injury, thoracodorsal nerve injury, intercostobrachial nerve injury, lymphedema, and Stewart-Treves syndrome are the 6 you need to know. Thoracodorsal supplies the lat dorsi, and so that's the boxer's nerve. They can't perform full extension, rotation, and adduction. That's an orthopedic kind of question. Your long thoracic, we know, leads to wing scapula if it's injured. And your intercostobrachial nerve, specifically, if you injure that, would lead to numbness of the medial arm. And that's the answer. That was for the question, which one of these was not a complication? It was numbness to the lateral arm. And I, like a big fool, chose skin flap necrosis when that's an obvious complication. So learn from my stupid mistakes, right? Lymphedema because it clears lymph nodes. And what is this thing about Stewart-Treves syndrome? Well, Stewart-Treves syndrome is a lymph. Do I have it here? Here it is. Right. It's a lymphangiosarcoma. So in patients with long-standing lymphedema, right, they could end up going on to develop an angiosarcoma. And this is called Stewart-Treves syndrome. So when they clear the lymph nodes, they end up with lymphedema, and well, of course, Stewart-Treves syndrome can ensue. So this is more the questions they ask about MRM. So when it comes to treatment questions, guys, the indications, contraindications, complications for surgery are commonly tested rather than actually how you perform the surgery. All right, they don't expect you to be surgeons. They expect you to know what is the risks involved, what are the benefits involved, what are the indications, contraindications, what are the complications of it, and when you actually want to operate. All right, so think about surgery like that. If they are to ask you about actual surgery, it's when you're going to operate, what are the indications, what are the contraindications, what are the complications. That's the most they actually ask about, definitively ask about procedures. All right. So good. So that's MRM versus BCS. So once we do uh, modified radical mastectomy, guys, we can offer breast reconstruction. And what they like to ask about is what muscles you use if you are deciding to be autologous. So autologous means you're using the patient's own tissue. And the two muscles we can use would be the lat dorsi and the tram flap. Tram is transverse rectus abdominis myocutaneous flap. All right, so this I've seen this question come in the December paper. All right, what were the muscles that you can use for breast reconstruction? So learn that well. So that's for the autologous, and of course, a patient can have implants, all right? But for autologous breast reconstruction, the muscles most commonly used are your lat dorsi or your transverse rectus abdominis. Okay? Good. So are there any questions on MRM, BCS, or when to operate? It's inoperable. When it's inoperable, we do neoadjuvant first to make it operable, then we operate. Any questions on this aspect of it, guys? Are we clear? Okay, fantastic. Nice. Okay, let me just do this here as I'm here. Sorry, I now remembered something. I wonder if I can actually remember it, like properly remember it. So I saw recently in a question, it wasn't an MBBS question, but it says a good thing to know. And I tried to draw it out. Let me see if I could try to draw it out. So this is the patient's axilla, right? So let's put this in blue here. Let's actually put this in yellow here. Oh gosh. Give me a second, guys. Right, put that in blue. We put this in yellow. Oh my. Ugh. Real. Yeah, cool. Blue here. Put this in yellow here. Color coding is kind of important. Um, we put this also in another blue here, and a kind of lighter blue, and then we'll do something like this, and this, and this. Anyone has an idea what I'm drawing here? So what I'm drawing here would be the boundaries of the axilla, right? When you're doing an axillary lymph node dissection, right? I saw this question. So the boundaries would be the first one here. This superior boundary is the axillary vein, right? The kind of how you would say this, lateral. I think this is, yeah, this is lateral. This is your thoraco. I should write this in yellow. Thoracodorsal nerve, right? So if you don't see thoracodorsal nerve as an option, you can also see the actual muscle it supplies. That's the lat dorsi, right? But most times you will see the actual nerve. So the thoracodorsal, the inferior would be another vein, and this is your angular vein. And then medial would be, of course, your chest wall and ribs, right? And then kind of superior here was when I look at the surgery, there's this kind of thing here called a Halsted ligament. And I never actually saw an entire operation, right? But I saw this, I was interested. So it's somewhere in this region here, right? But this is where your lymph node is going to be here. So one question that can be asked would be the boundaries when you do an axillary lymph node dissection. So superior is the axillary vein, lateral is the thoracodorsal nerve, inferior is the angular vein, medial would be a chest wall. And then the other question that can be asked is how much lymph nodes you actually had to take out. No less than 10. So 10 or more lymph nodes when you're doing your axillary lymph node dissection. All right, so 10 or more. 10, 10, 10. Good. So that's just for completion's sake. I haven't seen it in MBBS, but I saw it recently. And I was like, I didn't actually know the boundaries and I had to learn it. So I say how to teach you all that. So learn it, it could come. Good. So we're almost done. Actually, should finish in time, hopefully. So this thing about a sentinel lymph node biopsy, I'm separating it as a whole because a sentinel lymph node biopsy is a separate thing. It's literally a biopsy. And again, but let's kind of draw it out here. This is the patient axilla. So let's say this patient axilla here. And let's say this is the woman's breast. So in a sentinel lymph node biopsy, you'd really opt for sentinel lymph node biopsy if you're doing breast conservation surgery, right? So, okay, that's probably a bad place to put the tumor, but you kind of get the point because it's involving a nipple, so we wouldn't do breast conservation surgery. We're not going to risk, right? The point is, if you're doing breast conservation surgery, you're going to chop out this, right? So you're going to take out the tumor. The next thing that you can do is you can do a sentinel lymph node biopsy. And a sentinel lymph node biopsy, you come through here, you start the incision here, and then you make an incision in what we call the hairless part of the axilla, right? Right? So what you're going to do with your sentinel lymph node biopsy is you're going to take a dye and you're going to inject it. Okay? So you're going to inject it in the breast here. And this is done, and I want you all to remember, sentinel lymph node biopsy is done injected, the dye is injected intradermally, right? So intradermally in the region of the breast there. The two dyes that we can use would be our technetium 99 and our methylene blue, I think is the name of that one. Right? I'm talking off the top of my head here, right, guys? But sentinel lymph node biopsy, basically, I was done. You inject the dye intradermally. Then you're going to take the lymph node sample from the hairless part of the axilla, right? And the stains that you're using are technetium 99 and methylene blue. So you're doing the sentinel lymph node biopsy, and a positive sentinel lymph node biopsy is where you have 2 or more stained lymph nodes. So you can write that down. Or if you have more than 10% uptake of your dye, right? So this is significant. And if you get a positive sentinel lymph node biopsy, then you have to do axillary lymph node clearance, right? So the concept behind sentinel lymph node biopsy is that the sentinel lymph node is basically the first lymph node that the cancer will spread to. So if you have a positive sentinel lymph node biopsy, it means that cancer has likely spread to the axillary lymph nodes. So if that is positive, then it is an indication, therefore, to do axillary lymph node clearance or axillary lymph node dissection. So that's the purpose of doing a sentinel lymph node biopsy, to see if the axillary lymph nodes are actually positive and if you need to do axillary clearance. But there are contraindications, and contraindications are sentinel lymph node biopsy is palpable axillary lymph nodes. It means that the axillary lymph nodes are palpable, the cancer spreads, so we don't need to actually do this lymph node biopsy thing. If the patient has a large fixed tumor, T3 to T4, or if they have inflammatory breast cancer, that's a contraindication. Multicentricity, if the patient had a previous lumpectomy, DCIS, and any patient who would not benefit from adjuvant chemotherapy. Because if the patient has lymph nodes positive, they likely are going to get chemotherapy and radiotherapy post-op. All right, so know these contraindications to sentinel lymph node biopsy. Know that a positive lymph node biopsy, yeah, so it's positive. If I recall correctly, you could check this from my right. I'm talking off the top of my head. It's if 2 of the lymph nodes are stained, and if you have more than 10% uptake, right? Or they take that with a grain of salt, but I'm feeling like that's correct. I'm teaching it, I'm seeing it because it sounds correct, which means it probably is correct, right? But that's what I think I remember Mr. Murad saying. If that changes, I'll let you all know. But that should be okay, right? Good. So that's sentinel lymph node biopsy. No, it's intradermal. We do in technetium 99, or we could use methylene blue. And that's the reason we do it, is to see if the patient has axillary lymph node spread. If the sentinel, the interpretation is, if your sentinel node is negative, it is unlikely that the other lymph nodes have cancer. So you don't have to do axillary clearance. It means that the breast cancer is unlikely to have spread because the sentinel node is negative. However, if it is positive, it means that it's likely to have spread to all of the axillary lymph nodes or some, so you just do an axillary clearance one time. Okay? So that's sentinel lymph node biopsy. It is a commonly asked question. Those are the two kind of points that I remember being asked as well. Good? And to conclude our teaching on breast cancer would be our adjuvant therapy and the indications and when we use what in who. So the first form of adjuvant therapy, guys, is chemotherapy. And you need to know St. Gallen's criteria for giving a patient chemotherapy. The most important prognostic factor overall for breast cancer is axillary lymph node status. The most important prognostic factor overall for breast cancer is axillary lymph node status. This is the most important prognostic factor for breast cancer overall. You see it and you never forget it. I don't want anyone to ever select lymphovascular invasion ever again. If, however, your patient has metastatic breast cancer, the most important prognostic factor in this case of metastatic breast cancer will actually be the hormone receptor status. That is ER/PR status. Why? Metastatic disease is already spread. This patient is only going to get palliative care. What will make that palliative care better is if this patient has something we can target to diminish the cancer, and that is hormone receptors. We have hormonal selective estrogen receptor modulators. So in patients with metastatic breast cancer, along with palliative chemo, you can also do palliative hormonal therapy. So if they have HR status ER/PR positive, that is a good, or I should say, not good because it's already metastatic, but it means that there's something to aid in the palliative care. If it is ER/PR negative, that is poor. So in a case of metastatic breast cancer, the most important prognostic factor is actually the hormone receptor status. Why am I stressing on that? For the past 3 years or so, they brought this question in a variety of ways. And the most important overall prognostic factor is indeed axillary lymph nodes. But if they tell you the patient has stage 4, that is breast cancer, metastatic breast cancer, then in that case, the HR receptor positive makes it, or HR receptor status is the most important prognostic factor. All right. So when will we do chemotherapy? Well, if the lymph node's positive, in a younger patient, tumor size 2 centimeters or more, higher grade lymphovascular invasion, hormone receptor negative, we have to do chemotherapy because we can't do hormonal therapy, but HER2 positive. So let's learn off your St. Gallen's criteria. Guys, the most important prognostic factor for breast cancer is the axillary lymph node status. All right? In metastatic disease, it then becomes the hormone receptor. Okay, status. Great. Please don't ever confuse that. The chemotherapy of choice is doxorubicin, and when we do a little bit about chemo in medicine, because I realize that sometimes they actually ask chemotherapy questions, we talk a little bit about the important chemos, right? So that is that. Next point about adjuvant therapy is that of hormonal therapy. So in a patient who is ER/PR, estrogen progesterone receptor positive, we have to look at the age and stage of the patient. Okay, I should just say age, because stage implies stage of the disease. When I say age and stage, I mean, is she premenopausal or is she postmenopausal? Our hormonal receptor positive patients who are postmenopausal ought to be on an aromatase inhibitor. That is anastrozole. So the drug of choice for ER/PR positive and post-menopausal women is an aromatase inhibitor. That is anastrozole. Why so? Well, in postmenopausal women, where do they get their estrogen from? It's most likely fat. Aromatase converts that estrogen into the fat. So if you it converts that fat, into the estrogen. So if you inhibit aromatase, you inhibit the conversion of fat to estrogen. You reduce your estrogen levels. And so an aromatase inhibitor is the choice of drug for hormone receptor status positive in postmenopausal women. It is not recommended at all for premenopausal women. Tamoxifen, raloxifene, those selective estrogen receptor modulators, that's what SERM stands for. Those indeed can be used, but they are far, far inferior and not the agent of choice in postmenopausal women who are ERPR positive. So postmenopausal women, ERPR positive, we do aromatase inhibitor with anastrozole. So I don't think anyone got that question correct. If, however, she is premenopausal, the drug of choice is a selective estrogen receptor modulator, tamoxifen. Yes, that is true. It's the best. But tamoxifen causes infertility, guys. So if in your question stem, your patient desires a family, and she's premenopausal, you are not giving her tamoxifen. You are either going to choose goserelin and goserelin only, actually, because orophorectomy is if her family is complete. She's going to take out the ovaries. So how you think about the hormonal therapy is where you're thinking about the level of the pituitary. Is your pituitary gland here? The level of the boobies, right? And then we say what's our third drug there? Level of the ovaries. That's supposed to be a fallopian tube. My gosh. Right? So at the ovaries, we can do oophorectomy. At the level of the breast itself, we can do selective estrogen receptor modulator with tamoxifen. And we said in our premenopausal women, tamoxifen is the drug of choice. Drug of choice is DOC, drug of choice. And we can also target the hypothalamus pituitary axis. And here we can use our GnRH analogs, such as goserelin. So that's how I remember how we target the estrogen, the premenopausal women, right? So premenopausal, we could target the pituitary, we could target the breast receptors directly, or we could target the ovaries. The drug of choice, if the patient does not desire a family, is tamoxifen. If she has completed her family, we can do oophorectomy. But if she does not desire a family, it's tamoxifen. If she completed her family, it's oophorectomy. But if she wants a family, it is goserelin. All right, because this will spare her fertility. Fertility sparing. Okay, good. So my entire class got the drug of choice wrong. I can't remember if I saw any correct answers for that, did I? Can't remember. Probably someone might have gotten it correct. Kudos to you if you did. Right? So that's how we interpret or how we apply the principles of hormonal receptor therapy. We have to look at postmenopausal versus premenopausal. We have to see if she desires a family or not. So apart from infertility, tamoxifen also has other side effects. One of them would be it increases your thromboembolic risk, so DVT-PE, and there's a risk of endometrial cancer as well. Okay, so bear in mind those are the side effects of tamoxifen. And then aromatase inhibitor. So remember, right? These ladies are getting their estrogen from fat. Aromatase converts the fat into estrogen. So if you give the aromatase inhibitor, you have no more fat being converted into estrogen, your estrogen levels drop. Just like in a postmenopausal or early menopausal state where you take out a woman's womb and ovaries, etc., you have to be concerned about osteoporosis because estrogen protects the bone. So in patients with aromatase inhibitors, you further, even though they are postmenopausal, yes, their risk of osteoporosis is increased already, but you further increase that risk. You further increase that risk of pathological fractures because now they have no estrogen whatsoever by giving them the aromatase inhibitor. And so therefore, we make sure that they get a DEXA scan and we start them on bisphosphonates to protect or prevent osteoporosis. And we do osteoporosis in medicine when we talk about calcium and so. Okay, so remember those things about anastrozole, tamoxifen, goserelin, and oophorectomy. Are we clear on this concept, everyone? Okay, fantastic. All right, and then the drug of choice for the immunotherapy would be our monoclonal antibodies. So if she's HER2 receptor positive, then the drug of choice there for HER2 receptors is trastuzumab. But if, okay, there's another question. So you give them trastuzumab for 1 year. I'm typing this in the chat, for 1 year. If there's failure to respond, then we can add on another drug, and that is called pertuzumab and pertuzumab. So that is for your HER2 new receptor positive, right? So trastuzumab, we give them for 1 year. If no response, there's another monoclonal antibody, and that is pertuzumab. So that is a distinction question if it comes. All right, good. And so this is just a picture of Nottingham Prognostic Index. We spoke about the most common location, upper outer. We said the most important for metastatic was ERPR. That is correct. But overall, the most important prognostic factor is exudative lymph node status. The most common route of spread for breast cancer is lymphatics. But if it's already metastasized, all cancers, the most common route of spread if they metastasize is via the blood. So hematogenously. The most common site of metastasis is the bone, right? So remember, it goes bone, brain, liver, lung, right? So that is that. And this is a little picture of Pagets. So I'll talk about Pagets. Then I will just guide you all through the benign breast diseases because they're very easy, and I expect you all to know everything about them. You can read this on your own assignment and supplement. All right? But breast cancer is really a big bad boy, but I'm not going to take it for granted. I'm going to point out these things after. All right? So for the Paget's disease, what I want you all to know about Paget's disease is that it is a ductal carcinoma of the nipple itself, right? So it's an in situ carcinoma of the nipple itself. And the features that make it more likely to be Paget's disease is that it affects the nipple first than before it affects the areola, right? Whereas if it's eczema, it tends to affect the areola first and then the nipple. So I have this little thing here that is comparing Paget's disease versus eczema. So unilateral makes it Paget's, whereas bilateral makes it more likely eczema. Menopausal makes it Paget's, whereas eczema is usually during the time of lactation. Other things I want you all to know is that there usually is a blood-tinged discharge with ulceration in Paget's. You don't really have a blood-tinged discharge in eczema. Okay, so Paget's disease has that classic presentation. It can be pruritic. Sometimes it's also non-pruritic, and so non-pruritic makes it more likely to be Paget's. Right? Eczema is itchy. Okay, so Paget's is usually non-pruritic. Right? Even though I have pruritus here, it's because it can have some pruritus at times and itch, but that's more classical of eczema. So know the differences between Paget's disease and eczema, and the treatment of Paget's disease, guys, is a wide excision of the nipple areola complex with adjuvant radiotherapy, particularly high yield point. Please take note of that. All right, good. So that completes our teaching on breast cancer. Are there any questions on breast cancer workup, management, risk factors, hormonal status, thing, blah, 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 bang? Any questions at all, guys? Are we clear? Because we got like 4 out of the 9 questions wrong, eh? Because when I see 5, 6 people getting it wrong, I say the entire class gets it wrong, even if 50 people would have gotten it correct. I want 100% of people getting 100% of the questions correct. So we only barely passed this breast part, right? So are we clear, guys? Any questions? Is there so yes, so neoadjuvant Ivana is before, neo is before, adjuvant is after. So neoadjuvant therapy is before surgery, adjuvant therapy is after or post surgery. So that's why we said for inoperable at presentation, that means the tumor is too big, you would give them neoadjuvant therapy. So that is before surgery, to make the tumor more operable. So we downstage it by giving neoadjuvant before surgery to make it smaller so that we can do surgery. And then after that, we can do adjuvant therapy, which is after surgery or post-operatively. Any other questions, guys? Are we clear? You're going to get 5 to 6 questions on breast. Bone, breast, liver, lung, yeah, that's the most cancers. That's most cancers would spread bone, breast, liver, lung. Most of them. Some have a greater affinity for one place than the other. So especially like there are certain things like there are questions they ask like when we do lung cancer and thing, you'll see that lung cancer has a certain the most common endocrine gland will be the adrenals because of the high vascularity, etc. So certain cancers have different specific points that is spread to, but for the most part, most cancers, you could just say it spread to the bone, breast, liver, lung, right? But definitely for the breast, bone. Oh, and as I said that, thanks for that, Dale. Remember that if it does spread to the bone, they have osteolytic lesions, okay? Osteolytic, not osteosclerotic, not osteoblastic. It's osteolytic lesions are suggestive of metastasis to the bone. Okay, so that word is important because you could say osteosclerotic and that's not necessarily metastasis. Osteolytic suggests metastasis. So thanks for that, Neil. Any other questions? All right, you're ready to move on and answer these questions for me? Yeah, no, we're still here. We fall asleep on the breast. Yeah. All right, cool. So good. I'll teach the benign breast diseases. I'll just guide the knowledge after we do the questions, and I'll teach our own questions, right? Because there's just certain things I need to look out for. Okay. All right. Good. So we'll start off with number 2. So answers to number 2 in the chat, please. Answers to number 2 in the chat, please. Fantastic, right? So I know I had seen some A's here because all you see bloody and say, well, bloody the most common cause is intraductal papilloma. Yes, but you need to look at the entire clinical picture, all right, everyone? So this is a 67-year-old one and say she old as hell. She's nulliparous. That's a huge risk factor. That's high estrogen exposure. She has a lump in the left breast that is hard and ill-defined and non-tender and behind the left nipple. So that is breast cancer type lump. Now she has a bloody discharge, and what we're looking for, it's unilateral, left nipple. It's the single duct. And well, the other thing they didn't tell us, but spontaneous. So that would have made it completely most likely for sure breast cancer. But given this information without seeing spontaneous, everything else points towards B. This is breast cancer, definitely. All right, number 3, let me just make sure everybody is clear about number 3. Answers in the chat, please. Right, fantastic. So this is a 59-year-old city worker, a 1-month history of having a non-itchy, persistent burning rash. So that word burning, burning is more classical to describe the Pagets rather than itching, right? So it's burning and it's non-itchy, it's persistent, and you find that the nipple and the skin overlying the areola is red and eczematous. So the nipple is involved more than the areola, right? And so this is pointing towards Paget's disease. Fantastic. Good. Number 4, I think we had a couple discrepancies here. So let me just see. Everyone, please just answer this because They love to bring this. Exceptional. So, which of the following is a risk factor for breast cancer? So, early menopause. Early menopause means that she saw less periods because she stopped seeing her periods at an early age. Late menarche means she saw less periods because she started seeing her period at a later age. So, early menopause, late menarche means prolonged estrogen exposure. It means more periods. So too does so too does I say in stupidness. Less periods. Sorry about that. Look, I mixed it up, right? So early menopause, late menarche means the patient saw less periods. So there's less estrogen exposure, right? She saw less periods. Multiparity means she was pregnant multiple times. She saw less periods. So less periods means lower risk. So A, B, and C is not risk factors. Breastfeeding is protective. However, if she decided to become pregnant after 35, it means she had this prolonged period of high estrogen exposure. It means she had more periods until she was 35 or what have you. So A, B, C, and E are not risk factors. The risk factors are early menarche, late menopause. So early menopause is not a risk factor. Late menarche is not a risk factor. Nulliparity is a risk factor, but multiparity is not a risk factor. Breastfeeding is protective. So out of these options, first full-term pregnancy after 35 is a risk factor. I tried to confuse myself there and all by Anthony. Yeah, I talking strippings there. Yeah, so let's be careful with it, right? Don't go in too confident and read what they say. Because sometimes they say which is not a risk factor. Sometimes they say which is a risk factor, and then you're all over the place. So just take your 2 minutes, read it properly. Don't choose the wrong answer. Easy math. Fantastic. Hmm. I think this was one where everyone. Let me see the answers to number 5, please. So 27-year-old female, breast cancer screening, family history of breast cancer, both parents, both her aunt and moms succumb. And she is BRCA. Imaging of choice for screening, MRI, exceptional. So we got that point, right? So we said MRI can be used in BRCA patients less than 30 as the imaging of screening for screening, breast implants for screening, and we said before, no, Julian, make sure you read the entire stem, right? Because if it is that she's just 27, we can probably do an ultrasound, okay? So make sure you read the entire stem. So she's MRI, because she's BRCA, but the other indications were breast implants and before breast conservation surgery if they want to do to rule out multicentricity, right? Good. Breast ultrasound for patients less than 35, mammogram for more than 35. We said mammogram BIRATS 5 is diagnostic. You will be looking for a speculated appearance with stellate appearance, speculated lesions, and clustered microcalcifications, not diffuse, not coarse, clustered microcalcifications, right? And CT cap, of course, would be for staging with IV contrast. Let's see this question here. It's the answer to this question. Number 6. That is number 6. Sorry about that, to be specific. Number 6. Answers to number 6. Excellent, right? So now they didn't stage to see if it was Mets. And that's probably the trick in this question. Because they didn't tell you Mets or not. But because they didn't tell us Mets, we have to infer they just mean the most important prognostic factor overall. And we said that is palpable axillary lymph nodes. But if I tell you, after this patient's staging CT, she had osteolytic lesions seen on her femur, what would be the most important prognostic factor then? Excellent, right? So in metastatic breast cancer, the most important prognostic factor would be ER/PR status. All right? Trying to remember something to tell you all and I forgot. Anyway, so we get that concept clear. So lymphovascular invasion is at the cellular level, and lymph node status is spread to the axillary lymph nodes themselves. So lymphovascular invasion. It's kind of complicated for me to explain, but I'll send you what's the difference, all right? Number seven. Fantastic, right? So the first time around, I don't think anyone had chosen this, and I don't know why. Can someone tell me why you all chose tamoxifen? Anyone who would have chosen tamoxifen? Anybody? I'd like to know why. Like when there's a common thing wrong, I'd like to know what's the reasons why. Because the other day when we did AFib, everyone had chosen rivaroxaban, and there were different reasons. Mark had said because that's what they give in hospital. Alicia said because that was the question that I had given them in his demo. Then somebody said they thought cholesterol was the same as vascular disease and some other reasons. So I like to know the reasons so going forward I can teach it. I just remember from radiotherapy they give postmenopausal women this. Honestly, I'm just more accustomed to hearing that one news because it sounds familiar. I associated ER/PR positive with tamoxifen. Okay, sure. Halima don't know, right? Good. So, so Julian, now we know the difference is ER/PR is separate from HER. So HER is an immunoreceptor, ER/PR are hormonal receptors, right? ER/PR is estrogen and progesterone receptors. And so in our hormonal receptor positive patients, we are looking at their age. We're looking at their menopausal. Is it premenopausal or postmenopausal? So if she's perimenopausal, guys, if she's perimenopausal, let's say she's spot on 51, then in that case, we give tamoxifen. Okay? So for perimenopausal, we give tamoxifen. Just in case they want to be very, very stupid, right? But in clear-cut postmenopausal women, we want to give an aromatase inhibitor to inhibit that aromatase, prevent that fat being converted to estrogen, decrease our estrogen levels, and so we would give anastrozole. In premenopausal women, yes, tamoxifen is the drug of choice, but remember it causes infertility, so she has to have completed a family or no desires for a family. If she's more than 40 and family complete, because of the side effects of tamoxifen, we may opt for an oophorectomy instead because tamoxifen leads to infertility, DVT/PE, risk of endometrial cancer. But if it is she desires a family, premenopausal, we have to go with the goserelin. All right? The goserelin is the drug of choice if she wants her fertility and to have children. That's a GnRH analog. And trastuzumab, the other option here, is used in HER because it's a monoclonal antibody. It's an immune modulator. So it's used in HER2 new positive patients. So the answer for this is indeed B, anastrozole. Fantastic. You're all paying attention. What about this one? What about number 8? Do you know why aromatase inhibitors are not the drug of choice for premenopausal women? The mechanism of action, Judy, of an aromatase inhibitor. So in a premenopausal woman, her estrogen levels come from where? Her ovaries, right? So an aromatase inhibitor doesn't target the source of her estrogen, whereas in a postmenopausal woman, the source of her estrogen is the fat, and it is the aromatase breaking down that fat and converting it into estrogen. So in a postmenopausal woman, the source of her fat has to do with the enzyme aromatase converting the source of her estrogen has to do with aromatase converting that fat into estrogen. In a premenopausal woman, the source of her estrogen would be her ovaries. And therefore, if we target the hypothalamic pituitary ovarian axis, we have control over the source of our estrogen. And then if we target the estrogen at a receptor level, that is SERM, selective estrogen receptor modulators, then we really targeted the best. So that is why tamoxifen, the selective estrogen receptor modulator, is best in the premenopausal women, whereas um, tamoxifen is inferior in postmenopausal women because that's not the source of their estrogen. We want to get the source. And that's why you choose aromatase in postmenopausal. But for premenopausal, tamoxifen, goserelin, or oophorectomy, targeting the source of the estrogen. That's a very good question, Judy. And it made me think about why. And that's why. Right? Good. Number 8, answers to number 8, please. Mm. Good. So again, is it that you all just never knew how to treat a DCIS? Because I think most people did not choose C. So can someone who did not choose C tell me why they chose, well, something else? Was it just the general thing about not knowing how to treat a DCIS in particular, or was there some other reason that you chose another answer? Okay, sure. That's fine. All right, so excellent, everyone. So DCIS, we do breast conservation surgery with post-operative therapy. However, if it's multifocal, so you see how they told us that she has one focal area, right? So that makes us narrow down our answer. Because if it was multifocal, then we would have done a simple mastectomy. But remember, in DCIS, we have no role to remove the lymph nodes. We have no role for chemo. The cancer it isn't spread as yet. It is in situ. It is contained. It doesn't cross the basement membrane. So it would not spread to the lymph nodes, so we don't have to do lymph node clearance. It would not spread to the body, so we don't have to give chemotherapy. We just do post-operative therapy targeted at the breast, following our breast conservation surgery. And well, we went through this a million times. Which of the following is not considered breast cancer? The answer is A, lobular carcinoma in situ. Right? Good. So I think we clarified. Let me see which ones you all had got wrong. I think some we get number 8 wrong. I think everybody got number 7 wrong. We got number 6 wrong. We got number 5 wrong. Yeah, we got about 4 out of the 9 wrong. So now we got those same 4 correct. So we got 100% this time around, right? And so now I will just do number 1 and 2. Before I do the benign breast disease in like 5 minutes, I just want to point out what's important and how they bring the questions. Are we clear about those things and concepts? I'll ask him one more time because breast is a big topic and you're going to get these types of questions and pinpoints, and I tried to give you all the information I could. Are we clear, guys? Any other questions? I had a couple of good questions before. Thanks for the questions, everyone. You all know I like questions. Any other questions? All right, cool. Good. So now we will just do number 1. So number 1 is a 38-year-old woman, nulliparous, with a 7-day history of left breast pain after being involved in a car accident. On exam, you notice a hard, irregular 3 centimeter immobile tender lump and some skin tethering and overlying bruising on the region of the lump. Right? Now, yes, she is nulliparous. Yes, she's 38 years old, but this history of trauma and this short history, 7-day history, the most likely diagnosis at this point is a particularly critical point to note in your question. At this point is a fat necrosis. But for something like this, of course, our next step would be to complete our triple assessment. We definitely need imaging, and if we're still unsure, we would definitely need biopsy. And it's not about if we're unsure or not. Once we do imaging, once we start triple assessment, we complete it, right? But at this point, clinically, we're thinking fat necrosis because of the history of trauma and the fact that she has pain in the breast with this kind of mass, right? So breast cancer doesn't typically cause pain, and then there are things like the bloody discharge and so on that we would have seen for breast cancer. So skin tethering, yes, kind of sus. Yes, she's nulliparous. But the most likely diagnosis at this point, because of that history of trauma, is indeed fat necrosis. All right. And then number number 2. Oh, we did number 2. We did number 3. We did number 4. We did number 5. Okay, so that's the questions. All right, good. All right, guys. So that is breast cancer. Now, benign breast disease does come. So, of course, you will get a question on it. My guide is a nice little synopsis just for you to read. I want you all to read Mr. Mraz's book about benign breast disease. But just for your sake, I'm going to summarize everything here. So, fibrocystic disease, think about cyclical nostalgia. So a woman gets breast pain around the time of her periods and she's young and her breasts are generally very lumpy. That is fibrocystic disease until proven otherwise, right? There are different things that happen. You have cyst formation, you have epitheliosis, which is hyperplasia of the duct epithelium, adenosis, and fibrosis. So these are actually the four components of fibrocystic disease and how it happens. So it presents as cyclical nostalgia with lumpy breasts. Usually it's bilateral nostalgia and usually it's bilaterally lumpy. All right. For these patients, we reassure them it's unlikely to be cancer. And there are other things we can do to treat. So I want you all for fibrocystic disease to know that supportive bra helps, vitamin E helps, danazole, yes, bromocriptine, the dopamine receptor, tamoxifen, and of course, ultimately we have to complete triple assessment. Jody gave me a question. I know you said tamoxifen is drug of choice for premenopausal women who do not want or complete a family. So just wanted to confirm where the rule of oophorectomy comes in. So oophorectomy is offered. So this is more for Jody. So Jody's asking, um, tamoxifen is the drug of choice for somebody who doesn't want to complete their family. Yes, that is true. So she's asking, then where does oophorectomy come in? So most of the times, oophorectomy comes in a woman who has already completed her family, and we just offer her that. We could say, all right, we could take out the ovaries. This is a source of estrogen. Would you prefer that? And in the case where, let's say, a patient has a high risk of endometrial cancer otherwise, or where they have a high risk of DVT-PE, then in that case, we might want to opt for oophorectomy instead. Because remember, tamoxifen will further increase their risk of DVT-PE. All right? Cool. That's a real clinical judgment call. So look out if you are tasked with that question, premenopausal, she completed her family, she's 40 on the dot, then look out for other risk factors that increase her risk of like DVT-PE, because that's one of the very feared complications of tamoxifen. Yeah, but yes, it is more as an alternative, Jody. Um, Tamoxifen remains the drug of choice in that situation otherwise. Yeah, you're welcome. So fibrocystic disease is premenopausal women, right? We went through that. So I want you all to know these things that you do for fibrocystic disease, right? So vitamin E can help, danazole, bromocriptine, tamoxifen. Just know it, right? And a supportive bra. Okay, painkillers. It's not cancerous, but we should complete triple assessment either way because that's how we look up breast masses. That's one. Fibroadenoma, we know is our breast mouse. It's freely mobile, it's smooth, it's round, it's well circumscribed. The mass will be hypoechoic because we said solid lumps on ultrasound are hypoechoic, whereas cystic lumps are anechoic, right? So our mass on ultrasound would be hypoechoic. The reason we're doing ultrasound is because it's more likely to be found in a young woman. So you see a hypoechoic mass in a young woman, it's well rounded, it's well defined, it's freely mobile, that's a breast mouse, that's fibroadenoma, right? So fibroadenoma is also known as breast mouse. Yes, clinically it's known as breast mouse, right? So we will complete triple assessment. However, if she's very, very young, we can just do an ultrasound. But again, guys, every breast lump that comes to you, every breast workup must be triple assessment. Okay. Clinically, if she's young, less than 25, we'll stop at ultrasound. But for all intents and purposes, your examiner asks you, what are you gonna do for a breast lump? Triple assessment is the answer. Okay. She can't take it out if she wants, but remember, most of the times we just tell them it's a breast mouse. However, if she has a strong family history of breast cancer or she herself is at risk of breast cancer, we excise the lump. Okay? We excise the lump. And if the lump is very large as well, more than 4 centimeters, we are going to excise the lump, send that for pathological testing to rule out a phyllodes tumor. Okay? So that's fibroadenoma there. Young girl, breast mouse, freely mobile, hypoechoic on ultrasound, strong family history of breast cancer, increased risk of breast cancer, we take it out. Otherwise, it's fine, we reassure her. but if it's very large, we can also take it out. Breast cyst, we're going to aspirate a breast cyst and send it for cytology. Okay, it's called a blue dome cyst, common in the age of 30 to 50, and it will be anechoic on our ultrasound. Good. Thyroid tumor is not a benign breast disease, completely benign breast disease, I should say. A thyroid tumor is also known as a cystosarcoma. What you need to know about a thyroid tumor, this is a thyroid tumor here, right? This is extremely, extremely huge, right? What you need to know about thyroid tumor is that it is extremely large, it is of mesenchymal origin, and though most of them are benign, it's a premalignant lesion. Some of them are premalignant and they can become a full-on sarcoma and cancerous lesion. So because though the most are just benign, some of them do have malignant potential. So it can be benign and just stay benign, or it can be benign and convert to malignant, right? In that case, because of that, I shouldn't say in that case, but because of that, the treatment for phylloids is to cut it out. So we'll do a wide local excision most cases, however, end up doing a mastectomy because the breast is already ruined, kind of, right? Look at that. You're just going to chop that out, right? You're not going to try and conserve anything. Poor lady. Okay, so that's not the origin of a phylloids, mesenchymal. It can be premalignant and it's extremely large. Okay. Next would be our duct ectasia. So our duct ectasia, look out for green discharge in your question. All right, so that's really what you're going to look out for. It's green discharge. Now the other thing about duct ectasia that they ask is the treatment. Now in duct ectasia, most of the times we do reassurance for duct ectasia. However, you need to know about Hadfield's operation, which is where you have a wide excision of the duct. And that is if when you do your triple assessment and so on, this patient has a high risk of breast cancer being mistaken for a duct ectasia. Okay? Most of the times they just tell you venous discharge and ask you what it is. It's duct ectasia. Other than that, treatment coming usually is reassurance once all investigations are normal. However, if she's high risk or she has some high level of abnormality, we do a wide excision of the duct. That's called a Hadfield's operation. All right. Next is our intraductal papilloma. Intraductal, we know, is the most common cause of bloody discharge. And what I want you all to know is the treatment of an intraductal papilloma. So it tends to occur beneath the areola. It's benign, so we're looking for things like bilaterally bloody discharge, it coming from multiple ducts, and the mass it's associated with, if it is a mass, is very small right beneath the areola, and it is not ill-defined, it is not craggy, it is not the features of a breast cancer mass. So the bloody discharge is multiple ducts, bilateral, and it is not spontaneous. She only has that bloody discharge when she squeezes the nipple, right? So it's the opposite of the things seen in a malignant bloody discharge. And so that's when we think intraductal papilloma is the most common cause of bloody discharge. It is not spontaneous, it is multiple ducts, and it is bilateral. That makes it more likely to be intraductal. And in that case, we need to know this as the treatment option. That is a microductectomy. That's the word they bring in exams. So intraductal papilloma, treatment, microductectomy. What it is? The excise in the duct as a wedge resection. Okay, so they could also say wedge resection of the duct. So that's also known as a microductectomy. So that's intraductal papilloma. That's how they bring that. Know how the bloody discharge presents. It is not spontaneous. It only comes out when she squeezes the breast. Multiple ducts, bilateral, associated with a benign mass below the areola. Right? Fat necrosis we just went through. It's a blunt injury, usually in obese middle-aged females. It can be painful. Sometimes it's painless. It's firm, it's fixed. It can present like a breast cancer because it's ill-defined and so on. So in this case, guys, fat necrosis, as I told you all, you always complete triple assessment for fat necrosis. Not kidding. We had a patient on the ward said that a old lady, 64-year-old lady, said that she hit the breast about 3 weeks ago, and now she noticed this big lump. Now this patient was admitted for other reasons. When I say, Auntie, you mean you hit the breast? and it had this big lump. She showed me the guys. I talking about a full-on fungating mass. So this brings the point that I would have left out during the teachings. Self-exam, breast self-exam must always form part of your workup as well and counseling, especially for your highest patients. Always know they know how to examine their breasts and so on, okay? So fat necrosis, yes, you might think trauma. Yes, you might think fat necrosis. It could very well be breast cancer. And that lady, unfortunately, actually did have stage 4 breast cancer with Mets. And that was the reason for all of her pancytopenia and thing that she actually presented for. Right? Galactosele is a subareolar cyst filled with milk, and we just aspirate that. So it's a painless lump. And this galactosele is very unique. It happens after breastfeeding stops, okay? But it's filled with milk, so it's a milky discharge that can happen subareolar, not out of the nipples, but out of a lump next to or close to the nipple, right? So it's a painless lump, and we just aspirate out that milk. And the last thing is the difference between mastitis and a breast abscess. So mastitis can be lactational and non-lactational. I have to show you all an image. I don't have it here. This is mastitis of the differences between lactational versus non-lactational mastitis. For mastitis, guys, it can be lactational or non-lactational. And the antibiotic of choice, if it's lactational, is flucloxacillin because it targets Staph aureus. Staph aureus is what causes that inflammation, right? That's your skin organism. This question came for MBBS in December. Patient had a breast abscess. What are you going to do? If it's small, needle aspirate. That's less than 5 centimeters. If it's larger than 5 centimeters, then we can excise and drain and allow it to heal by, this is secondary intention, not infection. Okay, guys? Excise and drain it. So needle aspiration for less than 5, and we can excise and drain for more than 5. Okay? So we can do image guided drainage if it's more than 5 as well, but the answer was excise and drain, I believe, because it was more than 5. All right, so that's that. So this was just a brief synopsis of what they bring for benign breast disease. Read up more. There is more to benign breast disease, but this is a really nice, concise thing to just throw in when you're completing your studies, because they hardly ever test outside of these concepts. But there is more to benign breast disease. Read Mr. Maraj's book. All your answers, however, should be found here for most of them, right? So, guys, that completes breast. Any questions? Any questions? Any questions? Are we clear on all things breast? Clear? All right, fantastic. I believe you all are clear because we went from 5 out of 9 to 9 out of 9, right? So we have distributed a lot of information today. Learn it all. All right, guys, learn everything. That's the good thing about surgery. Once you learn everything, you could say, all right, I will surely pass. Medicine, you could learn everything, still not pass. All right, but that's not going to happen to you guys. All right, everyone. So thank you so much. This was our first surgery class. I know it was long. I told you all surgery usually goes 6 to 9. I thought I'd have gone till half 8 today. I always underestimate how long things take to teach. Thanks for bearing with me. Thanks for sticking around. Any updates? So update wise, don't forget your homework. Advice, try and send it by before Monday. Other reason to try to send it before Monday is because if you send it late, I would be very tardy in sending you back the cardio homework answers, right? Because like I don't move on to rest. So yes, I will send you the answers, but you might have a little delay, right? It's literally like 80 something of you guys here. So to reply to all of you every single day obviously takes a lot of my time, right? So if you're lagging behind in terms of the homework, you'll get your answers later on, right? But you will get it. So try and do it in time before I move on to rest and before you move on to rest. Other than that, I think class was good. First time I actually wrote in surgery, it was decent. It was well received, I believe, because when I see you all get things wrong and get it correct after, that is good. So thank you everyone for being attentive. That was our first surgery class. The next class, I will let you all know what we're doing beforehand. because I need to see how to structure it in line with my medicine classes. So when I do GI the third week, I will do GI surgery as well. But the next class most likely might be on trauma. All right, but I will update you all accordingly. So happy Saturday, everyone. I will see you all on Monday, please God. Thank you so much. Fantastic. Take care. Thanks, guys. Thank you. All right, bye bye.